Welcome, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. David Brown from Houston. Welcome to Retina Synthesis, David.
Thanks for having me.
At ARVO 2022, David presented some very interesting results on the use of high-dose Aflibercept in the treatment of neovascular AMD. And we'd like to talk about that today. Why in the world would one think that increasing the dose of Aflibercept from 2 milligrams to 8 milligrams would improve treatment efficacy?
Yeah, it's a good question. You know, when I did the SAVE study, which was 2 milligram ranibizumab, we saw 4 letters improvement and improved anatomy in a treatment recalcitrant population. That led Genentech to do the Harbor trial and waste, I don't know, almost $1 billion, testing 2 milligram ranibizumab in treatment naive, and there really wasn't a difference. So, you know, would 4 times the Aflibercept dose do much? I think it would in treatment recalcitrant, but what it really does is just simple math. If you got 2 extra half-lives, you get 2 extra half-lives, and we can talk about that. But I think the reason some patients need a shot every 4 weeks and some people need a shot every 10 weeks is there are fast clearers of drug and slow clearance of drug. And the fast clearance drug are the ones that are in my clinic that need a shot of Aflibercept every month. They probably have a half-life of, I don't know, 4 or 5 days. And if I can get them an extra 10 days, that's a big deal. So I think that's the ultimate goal. This phase 2 study was really to see, is it safe? Would the increased viscosity be a problem for us? Would you have any hypertension issues? And to be honest, the improvements in visual acuity we saw were a bit of a surprise.
So can you tell us a little bit about the study design and the treatment results?
Sure. It was 106 patients randomized 1-to-1. It was masked, so everybody got exactly the same treatment paradigm. You basically got 3 loading doses of either 2 milligram Aflibercept or 8 milligrams. 12 weeks later, everybody got a dose. Then you had PRN dosing in between Q12 dosing. Primary endpoint was week 16. And then the readout I showed at ARVO was week 44. Results were certainly no safety signals, didn't have problems with intraocular pressure or inflammation, did not see hypertension issues. It's a small sample size, but it's reassuring. What was interesting was in this treatment paradigm where patients were probably treated less frequently than I would in my clinic. They tolerated a little fluid and they kind of pushed you to go a little bit. But in this population, there was certainly improved anatomy and visual acuity. Did not reach statistical significance because of the sample size, but it was close. P equals 0.07 for one of them. We did have statistical significance on absence of macular fluid at week 44 in the 8 milligram over the 2 milligram. So it looks like you are getting more anatomic drying with the increased VEGF, anti-VEGF. You know, whether this will be seen in the phase 3 that's coming up is yet to be determined, because in those patients, they're going to go against the label, which is 3 doses in Q8, which is probably more frequent dosing than the 2 milligram arm had in our phase 2 study. So
in the phase 3 study, in the treatment group, it will be Q12 treatment?
It's sort of a brolucizumab adjustment kind of thing, right? Where it's 12 and they can go down to 8. So that's already fully recruited. We should have the data next year. So.
How many eyes in that study?
It's big. I'd be lying to tell you I know exactly, but it's over 500.
And so the results will be available next year.
Yes, sir. Then the big question is what they do with 2 milligram of Aflibercept, right?
Uses to treat diabetic retinopathy.
It's a diabetic retinopathy. It would be a great choice if retina doctors would ever decide our data means something. So.
Or diabetic macular edema. Is the injection volume the same?
It's actually not. It's 0.07. That's about as the viscosity. You couldn't really put it in 0.05. So, for patients that have ocular hypertension or go gray with a higher dose, if you think about it, if you get 0.05, it's probably 6 milligrams, which is still pretty healthy dose.
So let's talk a little bit about half-lives. What's the half-life of a 2 milligram aflibercept injection in a nominal eye?
So that's an excellent question. And that data has only been done in very small studies. Diana Doe had, I don't know, 7 or 8 patients where they did AC taps and did a sequential. In that, the half-life was 9-10 days median, but there was a couple patients that had a half-life of 4. The best data on drug clearance half-life is actually the faricimab FDA filing. The FDA made them do PK curves on everybody. And interestingly, the half-life of that drug is about 8 days on average, but there's about 10% that it's less than 5 days, and there's about 10% that it's more than 11 days. So I think it's probably about the same. This molecule is about the same size. But faricimab and aflibercept are about the same size. They're both, full antibodies. So I would bet the clearance is pretty similar.
So how does the half-life change when you put in 8 milligrams?
It does. The half-life doesn't change. You just have 2 more half-lives, right? If you've got 8 goes to 4, 4 goes to 2, you get 2 more half-lives. If you're one of these people that's a 10 or 11 day half-life, that's going to give you 3 weeks, right? If you're a 5-day half-life, it's going to give you 10 days. So.
Would you reserve the 8 milligrams for the recalcitrant patient, or basically the anticipation would be that 8 milligram would be the first line treatment?
Yeah, absolutely. I mean, of course, if they price it at $8,000, it's probably not going to be. But if it's priced about the same as our current expensive anti-VEGFs, then why not go with the best drug you have in the cabinet?
So, what does this mean in looking at brolucizumab for those people who are still using it, and faricimab in terms of durability? That's what the goal is, durability here too, correct?
Yeah, absolutely. So in a treat and extend paradigm, even though none of our studies really show durability, if you dry somebody out, then you're going to extend them longer. So if you get a week or 2 more, that doesn't sound like much, but if it's a difference in taking, somebody's daughter having to get off school and drive grandma to my clinic, if it's 11 times a year versus 13, that's 2 more times they don't have to get a substitute teacher. So every little bit helps. And, there's a lot of argument in sort of the commercial side of these companies that if we don't have a 16-week drug, then it's not going to be marketable. All you have to be is incrementally better. You saw that with aflibercept over ranibizumab, right? It's not that much different, but it's a little better, and it's the market leader 5 times over. If you look at faricimab, which is probably the next contender, if you consider that aflibercept's an anti-VEGF molar blockade of 1, then our faricimab dose is about 2.4, because it's really got a lot of ranibizumab hooked on it, right? And so this is obviously an anti-VEGF number 4, right? It's 4 times the 2 milligram. So basically, faricimab competes with aflibercept positively, and that's yet to be seen. Then this will leapfrog that. So it's just incrementally trying to get more anti-VEGF in your same injection. So,
well, this is actually very exciting, and congratulations on being one of the pioneers of this high-dose aflibercept concept.
Well, I cost Genentech a lot of money on the Harvard trial. We'll see what happens with the jury's still out on this one. So,
all right. Well, David, thanks for your help with retina synthesis, and keep up the great work. We'll
thanks,
see you.
Carmen. Appreciate it.